Hello.
Hi, Satoshi.
Hi, Ki. Nice
Good to see you again in
to
here.
see you. Yeah, nice to see you. So tomorrow morning, you have to get up early in the morning. Very early.
Cik Pungsa dun.
For us to share our information this afternoon. First of all, each speaker will introduce himself and also introduce his hospital very briefly. So please start, introduce yourself and hospital less than two minutes. Okay, so first of all, Professor Hosono, please start, introduce yourself. 細野先生、ミュートになってます。
Okay, Professor Jory and Professor Kusudas, thank you very much for giving me the opportunity of this presentation. So I'm Shigeharu Hosono from Jichi Medical University, Saitama Medical Center. So first of all, I will introduce our NICU. Our NICU opened at 2010 and it's located Saitama Prefecture next to Tokyo. So there is 9 beds in NICU and 12 beds in growing care unit. 9 doctors, including 2 pediatric residents and 34 nurses and other medical staffs, as shown in the slide. So we treated about 350 patients every year, but there is no experience about treating microphthalmia in this hospital. So I will talk on the basis of the experience of working in the previous hospital. Thank you very much. So next speaker, please.
Next, Dr. Ogawa.
Hi, my name is Ryogawa from Nagano Children's Hospital. Andどっから行ってみる？何を流してもらう。動画ですか？
Hello, we would like to introduce our Nagano Children's Hospital.
Excuse me.
ズームの画面出していただいて、画面共有っていうのが多分あると思いますし、そうですね、これです。
Dr. Itoshima, my coworker, made the introduction movie. Please watch the introduction movie.
We would like to introduce our Nagano Children's
Can you see the movie?
By way of neonatal care. First of all, I want you to know our location. We are in Nagano Prefecture, which is located in almost every part of Japan. There are many high mountains around our hospital, and we are surrounded by nature. Our hospital is famous for its beautiful and colorful appearance. Roof is delta shaped and repeated, and there is a clock tower on the top. When you first have a look at this, I'm sure you can't guess what this colorful building is. Nagano Children's Hospital plays a key role in neonatal and pediatric intensive care. This is why every maternity hospital and ICU in our area will make a phone call if they have ill neonates. We have a neonatal transportation system, and doctor and nurse in our unit can go and take the baby to our NICU 24/7. Of course, maternity transportation before birth is recommended. So many of very preterm infants are born in our hospital. We have resuscitation room on the same floor of our unit, and we also have delivery room and operation room cesarean section next to the resuscitation room. When a very preterm infant is born, we resuscitate and stabilize the neonate. We try our best for the baby to meet and touch the mother. After the bed, we take the baby to our unit. We have 42 beds in our unit, which is divided into 7 small rooms, and it has 4 to 6 beds. We have one private room, and parents can stay with their baby just before discharge home or baby on terminal care. For a neonate under 25 weeks, we routinely use fentanyl to avoid intraventricular hemorrhage. During their first 3 days, we usually don't use heart rate monitor and insert umbilical catheter bolts to avoid skin trouble. Thanks to our high quality and delicate neonatal care, our survival rate is quite high, and we could save a tiny boy whose birth weight was 58 grams. He is now 1 year and a half, still doing well. And he can even go up the stairs to follow his mother. Not all satisfied with this, because even now, the neurological prognosis of very preterm infant is no good. We want to know many other good ways of neonatal care. We do welcome you to our unit if you want. Please visit us and let's discuss for better neonatal care.
Thank you.
Okay, thank you. So next, Dr. Hirano.
Okay, nice to meet you. Can you hear me? Hear me?
Yes, I can hear you.
I will share my slide. Just a moment, please. Oh.
Oh, okay.
Sorry.
Sorry, I made you co-host.
Okay.
You should be okay now.
You can see my slide. Oh, I put the garment. Oh, sorry. Just a moment, please. Oh. Can you see?
平野さん、こっちで共有したから大丈夫です。
すいません。Thank you very much for inviting me, and I'm very happy to be here. I am Shinya Hirano at Osaka Women's and Children's Hospital. So this hospital, our hospital is located at almost the center of Japan. So next slide, please. So our hospital is just in 1981. So at 1991, the Research Institute and Children's Hospitals combined. the total death is 363. And our NICU, so number of total births is about 1,600 babies per year. So number of admission in our NICU, about 400 to 500 per year. And 70 to 80 very low birth weight, and 30 to 40 to ELVW. And also we have transportation systems. The number of neonatal transfers about 250 to 300 per year. Next, please. So our NICU, this is a neonatal intensive care unit, a little bit called packed. And next slide, please. So this is a special person. Next slide, please. This picture shows a growing care unit. So our NICU has 21 beds. GCU has 24 beds. So doctor is a number of doctors 15, including the 2 residents. The 17 nurses are worked with us. Next, please. Oh, this nurse is specialized for neonatal care. So we have 2 special nurses for neonatal care. Okay, next slide, please. So this is our data. So these are the number of admission in our NICU from 1981 to 2019. So you can see that as the number of the admission is getting increased, but so more than 1,000 gram, so little bit bigger babies, the rate is increasing. So lower on depend on the gestational weeks. So you can see 20 to 23 or so less than 26 weeks, the number is a little bit so decreasing. So next slide, please. This is admission. This is the rate of the patients. So you can, the lower is depend on the gestational weeks. So the purple bar means 27 to over the 27. So the number of less than 27 weeks is decreasing, the rate is decreasing. So on the other hand, more than mature babies, the number of the more than mature babies is increasing. Next slide, please. So limited to less than 17 gestational weeks. So you can see around 30 babies admission. So you can see the blue bar. Blue bar is more immature babies. The number is getting increasing. Next slide, please. So limited to the birth weight less than 1,000 gram. So you can see total number is getting decreased. But the rate of the 500 gram, the number of the less than 500 gram is increased. Please, next, please. So this is our data about morbidity rate. So birth weight less than 1,100 grams. So the left upper, the IVH, the severe IVH, almost 5%. So PVL almost less than 3%. So PDA is a little bit, relatively constant. So ROP treatment is 3 to 4 nowadays. So CLD is its number rate is a little bit increasing. NEC is 2019 is increased. But with caution, so we understand that the background of the baby is different. So recently we have more sick babies or more tiny babies. The rate is with caution, the understanding. Next, please. So this is our mortality rate. So upper one is depend on the birth weight. So 500 to 1,000 grams, and almost constant, less than 10 or 20%. But 500 grams, under the 500 grams, the mortality rate is up and down, so depend on the year. So I think so there is still room for improving for the management of such a tiny babies. And also 22 or 23 week is also the same thing. So the rate is, mortality rate is up and down. Next, please. Oh, this is a rare data. So we don't have a much 22 weekers. So, but the outcome of the 22 weekers are like this. So 22.3 is the best to development delay is 2. 22.4 development delay 4. All of them are development delay. So 22.5 is like this. So how about less than 500 grams? We have 41 cases, and survival at discharge is 16 cases. So we assessed this at 6 years of the developmental assessment. So neurodevelopmental impairment is 7 cases, almost 40%. No NDI is 26.1%. Next slide, please. This is the end of, okay, I'm sorry to taking a time. So this is our hospital's situation. Thank you.
Okay, next, Dr. Nakanishi.
Yes. I want to share my slides. Is it okay? Oh, okay. Can you hear me? Yes.
Yes.
I'm Hidehiko Nakanishi from Kitasato University. Nice to meet you again. I'm so happy to see you again in this web seminar like this. And I used to work in the Tokyo Umezu Medical University, and from 2018, I moved to here at Kitasato University. This is the location of Kitasato University. You know, this is a Japanese map, and next to Tokyo, the Kanagawa is located like this. And this is Kitasato University.
I think we cannot see your image.
Oh, really?
Yes, I can see your face, but not slides.
Not slide. Okay, hold on.
Please share the.
Ah, okay.
Yes,
I'm
sir.
sorry.
Yeah,
I'm sorry. Okay.
I can see. Yeah.
Now you see? Okay.
Yes.
Ah, okay. I'm sorry.
Mhm.
Let's start again. I'm from Kitasato University. This is the location of Kitasato University. You know, the Kanagawa Prefecture is next to Tokyo. The Kitasato University in the Kanagawa Prefecture here. You know, the Hakone Onsen is very close to our hospital. So if we want to come here, I take you to the Hakone Hot Springs. This is the outlook of the Kitasato University. In the Kanagawa prefectures, this orange color means level 3 tertiary care center. In Kanagawa prefecture, 1, 2, 3, 4, 5, 6, 7 big hospital which have the NICU. And Kitasato University is here. This area we responsible for the maternal delivery and neonatal patients. I showed some video, okay? This comes from some TV programs. We have the 23 NICU beds. Especially in here, we treated severe newborn babies. So we have 23 NICU beds, and we have 10 GCU beds. And we have 5 certified neonatologists and 2 residents. And nothing stopped 45 in NICU, 15 in GCU. nursing staff in NSU taking care of the baby of 3 babies. And while the nursing staff in GCU, they have to care the 7 patients. Other than the neonatologist and the nursing staff, we have the pharmacist and the psychotherapist and the physical therapist, radiological technologist, and medical engineering like this. Okay. That's my presentation of Kitasato University. Thank you.
Okay, let's move to Dr. Isayama.
Hello, my name is Tetsuya Isayama. I will briefly introduce my hospital. Can you see my screen? I believe. Yes. So I'm working in the National Center for Child Health and Development, NCCHD, in Tokyo, Japan. And our hospital is the only one national center for children and mothers in Japan. And we have a big children's hospital and also serving for the mothers. And also we have a research center. They have a many research group. And also we have a clinical research center. So we are the hospital and also research institute. Oh, sorry. And I have to. So our NSU, in the past, I worked in Toronto in Canada 6 years, and I came back to Japan to work in this hospital in 2017. And our hospital have level 3 NSU 21 beds, and level 2 we call the GC Growing Care Unit 30 beds. And staff is neonatologists 10 doctors, and the fellow or residents or 5 now actually 8 doctors, and we have nurses 80 nurses. And so our hospital admission is 380 admissions per year, and we take care of the all kind of the sick babies, including the extremely preterm infant from 22 weeks, and also all kind of surgical cases, cardiac, GI, neuro, eye, very sick babies. And also we have a group who perform the fetal surgeries, including twin transfusion and chronic congenital diaphragmatic hernia. This is a NICU. This upper part is showing 9 beds for the, especially for the surgical cases. And these are for the very small babies. So this is our NICU. Oh, thank you. So, stop.
Okay, thank you. So we have already spent more than 25 minutes. Just only introduce yourself and your hospital. So we have to hurry up. So first of all, I would like to show the summary data of Japanese database. So I think you can see my slides. Okay. So just introduce neonatal care for micropremies in Japan. So these are today's participants. And also today we focus on the infant born before 26 weeks of gestation. So these are maybe equal to micropremies. So this is micropremies, maybe around 340 grams. So today we focus this kind of infant. So today, just I want to explain the current status of outcomes in Japan, and also just show the practice, and also we don't have time, but just explain the situation of nursing staff. So this is our database result from 2003 to 2016. So we are running a neonatal research network database since 2003. And this is mortality rate according to the gestational age, 22 up to 25. And this is died during stay in NICU. These are died in delivery room, and these are survivors. So these are numbers of infants, and you can see 22, almost more than half, couldn't discharge from NICU. However, baby born at or more than 23 weeks of gestation, more than 70% of infants discharged from NICU. What's the trend? Looks improving. So 2003 to 2016 looks improving, but still talking about 22 weekers, around 50% mortality. So what about long-term outcomes? So this is a rate of neurodevelopmental impairment at 3 years of age. So you can see the numbers of infants we followed up, and 22 weekers, 40%, they may have some kind of neurodevelopmental deficit, MR, cerebral palsy, hearing disturbance, or visual disabilities. So we should improve these outcomes. And in developed practice, after me, so Japanese specialists introduced our daily practice on resuscitation, respiratory care, prevention of CLD, psychiatric care, nutrition. Last year, we published this manual. Julie actually helped much to publish this manual. Unfortunately, this manual is free to download from our website. So we couldn't make any money by publishing this manual, but we are very happy to share this manual. So anytime you can download this manual from here. And talking about nursing staff, maybe Japanese nurses are not happy about this situation. One nurse have to take care 1 or 2 infants, daytime and nighttime. They have to take care 3 infants at least. And most of NICU are 1-floor system, and no nurse practitioner, no respiratory therapist. So everything, all cares done by nurses. So we hope we can have some more staff, or we can have assistant staff, but not possible at the moment. We have a video with English subtitles. So if you want to see this video, I can send you. But today we do not have time, so I just show you the example of our video for nursing cares. Key is here because they visited 2015. I can see many faces also today, and we visited Australia 2016. So our communication already started 5 years ago. So again, we are very happy to share information with you. Okay, so time is limited, but if you're okay, please explain the individual practice in Japan. So, Julie, okay, continue to talk from Japan.
Yes, please. Yes, keep going.
Okay.
Thank you.
Okay, so first practice is resuscitation. So, Dr. Hosono.
Yes. Can you share the slide?
It's already shared.
Yes, we can
Okay.
see the slide. Thank you.
Yeah.
Okay. So today's my talk is the management of micropremi in the delivery room. So micropremi essentially required intensive resuscitation. However, there is no difference in the resuscitation steps between micropremi and the other infant. So we use neonatal cardiopulmonary resuscitation algorithm 2015 derived from NLP algorithm. So this Japanese algorithm has two flows. One is a life-saving flow and the other is a stabilization of the breathing flow. So I described the summary of NCPR guideline 2015. So I sent this paper to Julie by the attachment to yesterday. Please refer it in detail. So this slide is a summary of the specific management of difference between micropremi and other infants. So I emphasized these 4 items. So placental transfusion, temperature control, ablation of back and mask ventilation using a capnography, and surfactant administration. So placental transfusion is achieved as one-time umbilical milking in Japan. So delayed cord clamping generally interfered with resuscitation in the micropremies. So we choose cord milking. So benefit of this procedure are less invasive compared with multiple umbilical milking with intact cord. To be more specific, less blood pressure fluctuation and earlier respiratory support. So however, milking is not indicated for the infant born at less than 24 weeks of the gestation because of the possibility of the risk of the IVH. So this is a short video. I will show you a short video. So umbilical milking, umbilical cord is clamped and cut at 30 centimeters from neonate. So umbilical is usually twisted. So release twisted first and then milk the umbilical cord slowly. So next slide is a method of prevention of hypothermia. So use of radiant warmer and increasing in delivery room temperature are essential. So drying skin using a gauze, not towel, and you should press shortly, not scrub gauze the infant is important. So because fragile skin, infant is muffled plus scrub after the drying. NLP textbook recommended without drying, but in Japanese with drying. So this is a mask and back ventilation is also essential procedure to save such a tiny infant. However, it is difficult to evaluate the efficacy of mask and back ventilation on the basis of clinical findings such as increase in heart rate, auscultation of air entry, elevation of chest wall, and changes in color, skin color, because high incidence of respiratory distress syndrome or immature lungs. So capnogram provides useful information of the ventilation. So capnogram can detect CO2 in the micropremise. So we use a side stream type of the capnometer because of dead space is smaller. So this is last slide. So surfactant administration is considered in the infant born at less than 26 weeks of gestation and suspected respiratory distress syndrome. And the infant was required both high oxygen concentration and high inspiratory pressure. So microbubble test and chest X-ray film performed in NICU after surfactant administration is useful for the diagnosis of respiratory distress syndrome. So thank you very much for your attention. Do you have any question or comments?
I have asked the participants to type in their questions in the chat room. So if there's anything, please type in your questions and I shall put it to our colleagues in Japan.
Okay, so probably time is limited, so maybe go forward hearing all speakers, then
yes,
we're going to have a Q&A session. Okay, so next, Dr. Hirano about respiratory care.
Could you show my slide, please? Professor Kusuda. I cannot.
細野先生が画像共有を止めてもらえますかね。
这样好吗？Mine, I cool. I wanted to cool for my this thing.
again, please mute if you're not speaking.
Okay, thank you. I would like to talk about respiratory care. So these are many ways for respiratory care or respiratory management. There's no uniformity, so various management depend on the baby's institute and ventilator availability. So I had liked in the NRN NICU manual, which Dr. Kusuda previously mentioned about and each respiratory care, some modality or something like that. So I would like to talk our management in Osaka. Please, next slide, please. So our management for less than 26 weekers. So I would like to talk delivery room to the respiratory management. At delivery, so the temperature is more than at least 30 degrees Celsius. So intubation was carried out as early as possible because of almost no chance without artificial ventilation in such a tiny babies. And also we give the surfactant to be the endotracheal tube. So the volume is mentioned in the slide. So we start to ventilate the babies in SIMV, synchronized intermittent mandatory ventilation, plus pressure control support. So you can see the initial settings around PIP 18, PP5, frequency 40, high times 0.4 to 0.6. It's a general settings. So we use the data, so SpO2 or PaO2 monitoring. So we usually try to avoid excessive oxygen, hyperoxygenation. We start, I think, so the FiO2 is around 40. So, and the line is inserted, it's a PICC line, so peripherally inserted central catheter, and single lumen and double lumen. The two routes we usually take the PICC catheter route. So umbilical vein is sometimes we use, but not routinely use the umbilical vein. So, and more line is arterial line. So we don't avoid umbilical, we don't use umbilical artery as much as possible. We try to peripheral arterial line. So, and we also give the sedative drugs. So usually we use the fentanyl, 0.5 microgram per kilo per hour. That is the concentration is starting dose. And in the delivery room, we did cardiac and brain echo and go to the NICU. Next slide, please. So these are the typical management pictures. So intubated, and this baby has peripheral lines, not a PICC line. So, and the blue, green and purple one, you can see these are the double lumen PICC catheter. And upper one, so we take arterial line, peripheral arterial line. So these are the typical picture of the tiny babies. So next slide, please. So we usually keep the room temperature of our NICU to 28 degrees of Celsius. Humidity is 50 over 60%. So incubator was, the temperature of the incubator is like this. So depends on the gestational weeks, and the temperature is a little bit different. So humidity of the incubator is also settings. So less than 750 grams or more than 750 grams. So a little bit humidity is different. So less than 750 grams, 7 days after birth, we keep the humidity 80% in the incubator. And this, after that, 60% and more 7 days and off. Next slide, please. So this slide shows the general management of our NICU for the respiratory care. The start SIMV, duration is about 3 days or 7 days or so, and change the high frequency oscillation to depend on the baby's condition. And probably after 3 days of life. So change IMV and NAVA, neurally adjusted ventilator assist. This kind of the respiratory care is we've learned from the Nagano Children's Hospital. So we now try to NAVA, so to prevent the severe chronic lung disease. And extubation. The time of extubation is around collected 28 or 30 gestational weeks or so. I think it's a little bit later than other hospitals. And change the non-invasive ventilation, NIV-NAVA and CPAP, DPAP, and high flow nasal cannula. And also the SpO2 is very important for the prevention of the chronic lung disease. So for less than 28 gestational weeks or less than 1,000 grams, less 7 days after birth, target SPOs around 90 or 95. So 7 days or collected 36 weeks or less than 95%. And over collected 36 weeks, 90 to 98%. This is a general management for our NICU. So just briefly, I talked. Thank you.
Okay, so let's move to prevention of CLD. Dr. Ogawa, please.
Can you hear me? Okay.
Yes, all good.
Yes.
Sorry. I'd like to give an outline of what I'm going to discuss today. First, Japanese criteria. In Japan, CLD is classified into 7 diseases. Sorry.
小川先生、スライドショーにした方がいいかもしれないね。
Sorry.
Can you see the slide? Or slide? Okay.
Okay.
Yeah.
So, let's start please. In Japan, CLD is classified into 7 disease types, according to the predisposing pathological condition, RDS, count, and chest X-ray findings. Japanese neonatologists focus on foamy or emphysematous shadows on X-rays because respiratory prognosis is poor in type 1, 3, and 4.
ドクター小川、スライドがタイトルスライドになってますけど。もしあれだったらこっちで出すこともできますけどね。
そうですね。ちょっとお願いしていいですか？
じゃあちょっとやってみますね。
伊沢先生、スライド持ってる？
はい、多分これ、最後に送ってもらったやつだと思うんですけど、ちょっと待ってね。
こっちはね、
画像共有を一回止めてもらえるかな？小川先生の方で。
OK ですか？
まだ共有されてるね。なんか止まっちゃったのかな？
Julie, can you stop the sharing the slides? Oh, yes.
Oh, yes, yes, yes. Good, good. Okay, I will. Can you see my slide?
Yeah. Next slide, please.
Okay.
Next slide. Next slide, please. Now, let's start. Children with these findings in the neonatal period had significantly impaired lung function from 8 to 12 years of age. Next slide, please. Prevention and treatment of CLD. Next slide, please. There is no one best and established methods. All efforts should be made to prevent and ameliorate its severity. Next slide, please. Limited use of oxygen after birth and at chronic phase is effective. In Japan, many facilities use HFOV, but there is no evidence for prevention of CLD. Likely, early expansion is effective. Next slide, please. There are some therapies with weak benefits. Systemic steroid administration is the most effective drug. Inhaled steroids and caffeine administration are effective to reduce severity. In both treatments, starting within 24 hours of birth is very important. Diuretic administration improves lung compliance in the short term, but there is no evidence for prevention of CLD. Next slide, please. Tiny babies of outcome of NAGA. Next slide, please. The table shows outcomes for infants born at 22 and 23 weeks gestation of Nagano Children's Hospital. Incidence of infants with survival discharge were 85% at 22 weeks and 89% at 23 weeks. Proportion of NEC were low. I don't have long-term outcome of these babies. I'm planning to collect long-term data in future. That's all for today. Thank you for your attention.
Okay, thank you. So next speaker is Dr. Nakanishi.
Can you hear me?
Yes.
Yes. But time is limited.
Okay.
30,
That's okay. That's very good.
36 slides is impossible.
Okay. My part is
It's all
psychiatry and group
recorded.
management. Yes. And sorry?
It's all recorded.
Okay. I would like to start with the resuscitation. Okay. This case is a 24 weeks gestation in the Kitasato University. The mother was delivered emergency cesarean section. This baby is a 24 weeks gestation. I just like to show you the how to resist the baby because it's very important to manage cardiac function after birth. Okay. Anyway, we're very careful about the body temperature, and the delivery room is very warm. We seldom use a prophylactic use of the surfactant treatment after stability of the cardiac heart rate, and then we intubate the baby like this. Okay, but anyways, intubation is succeeded, and the baby will transfer to the NICU. Okay, before going to the NICU, the mother can see the baby. Okay, and the baby will transfer to the NICU. Baby will transfer to the incubator. Okay. So the first thing I'd like to talk about the importance of heating and humidification. The lower gestation, the much more amount of the insensitive water loss. So the baby promptly accommodated in the closed incubator until 72 after birth. We keep the baby the 100% of humidity to minimize insensitive water loss. From day 3, we gradually reduce the humidity, promote the skin condition. So this is the vascular access of a human baby, especially in 20-24 weeks gestation. we like to use the umbilical cord catheter. And we also use a PIC catheter. In Japan, there are some great Japanese product which is coated with polyethylene glycol, silicone, and aliphatic hydrocarbon, which has a high biocompatibility membrane in the high and continuous anticoagulant effect, inhibition of microbial establishment, and inhibition of inflammation. Next slide shows the general food management. Water quantities. We take the water intake usually starts at 60 to 8 milliliter per kilogram per day, and then go up by 10 milliliter per kilogram per day according to the urine output or something. Finally, we go up to the 120 to 130 milliliter per gram per day, which might be the dry sided compared to the other countries. But that's very important for the management of CLD or something like that. Humidity, as you know, I showed you already in 22, 24 weeks of gestation, the humidity is close to the 100%. You know, three important components of the food management of ELBW is the natural sodium and the potassium and the calcium. The concept is the same as other country, I think. Actually, in our NICU, we have the electronic chart. By using this, we figure out how manage the food management. This in is a volume intake, and out is a urine output. Day 0, day 1, day 2, day 3, the baby shows the output is good. So we consider the nutrient supplementation will be started on day 23, and the potassium supplementation on day 3. Otherwise, if the baby is in out balance like this, that means the low output, low out. That means the sodium and the potassium supplementation will not be started. The next slide shows the psychotic support. This is a list. We routinely use of the double lumen intravenous catheter. Not all the hospitals in Japan, but in our hospital, we like to use a prophylactic use of in medicine for infants under 24 gestation weeks. And we routinely do the echocardiography at the bedside by attending neonatologists. Early detection of PDA might lead to the early intervention. So we concomitant use of the dopamine and dopamine, and sometimes we supplementary hydrocortisone treatment for hypertension. That's echocardiography by neonatologists. This slide shows the actual examination in the NICU. The baby is 24 weeks gestation in the incubator, you know. The regular in the every day, sometimes twice or 3 times a day, we routinely do the echocardiography. We check the cardiac function like this. This is M mode. As long as this is PDA checking. Fortunately, this baby has no sign of the PDA. This is anterior cerebral artery flow pattern. By looking at this, we evaluate organ flow. What kind of index of evaluate by echocardiography is this is the right heart preload marker is IVC versus the descending outer. And this is foot of heart preload, is the ventricular dimension. And this shows the left heart preload plus outer ratio. And also we check the contraction as indicated by the EF. And as a marker of the afterload, we like to take the ESWS. If this value is more than 40, the afterload goes up. And also we check the chest X-ray to evaluate like this. If we see some hypertension, we check the 3 important factors: preload, contraction, and afterload. And if the preload is decreased, we administer the volume loading like sarin, and FAP, RCC, and 5% albumin, or increase in drip infusion. If we see the contraction is decreased, we give the cathepramine, dopamine and dopamine, and hydrocortisone, and calcium gluconate hydrate, and sodium bicarbonate. If we see that after load is decreasing, we administer hydrocortisone, but pressing, sometimes the baby suffer from the sepsis. We try to do the exchange transfusion. This is some special pathological condition, late onset cyclic collapse. This is pathology, might be the relative adrenal insufficiency or prematurity. This complication is very severe, like a postnatal PVA and cerebral palsy. To decrease this complication, we quickly administer the physiological dose of hydrocortisone if the baby shows some symptoms. Sometimes the baby shows the abnormal organ flow patterns by the echocardiography. This is a superior mesenteric artery flow pattern. This is normal, but the anterocerebral artery and the renal artery pattern is abnormal. And then we administer the steroid. There's an onset of the symptom. Anterior cerebral artery flow pattern is disrupted, and then after administration of the hydrocortisone, the organ flow is improved. And to prevent severe neurological development, we have some standard. We have the criteria of steroid treatment for premature infants. That's like a standard criteria for administering the steroid treatment. This is a clinical finding of hemodynamic system PDA. That's a common thing, so you have already known. Okay, so what I want to talk to you in this slide is the PDA treatment. We usually use the medication and the medicine, and also supportive management. And we also do the surgical treatment. The indication is like this. I think that this indication is also very important due to repeated reopen and enteral feeding is not good. So we think about the surgical treatment. I'm sorry to a long presentation. I'm finished. Thank you.
Thank you. That was fantastic. Thank you.
Okay, so final presentation from Dr. Isayama.
Yes, I want to share. Can you see my screen, I think?
Yes, thank you.
Yes, yeah. I'm not a specialist for the nutrition, but other people talk about the resuscitation, the respiration. So I will very briefly introduce the enteral feeding practice in Japan. So as some of you may know, we have some data from the International Neonatal Network for Evaluation of Outcome, INEO, published. This was data presented in the PAS meeting in 2015. This is a necrotizing enterocolitis rate among the countries. And as you may know, Japan has a very low rate of the necrotizing enterocolitis, and Australia and New Zealand is here. And this is a adjusted result. The y-axis is a standardized risk ratios of the necrotizing enterocolitis, which means that 1 is a average, but less than 1 means less compared with the other countries. As you can see, Japan located a very low rate of the necrotizing enterocolitis, especially after adjustment for the severity of the infant. And this is data in the NRNJ manual. So you can see that in the manual. So this is the data of the neck rate and FIP rate. FIP is a focal intestinal perforation. So sometimes called the SIP. So spontaneous intestinal perforation. And as you can see, that over the years, the rate of the neck is not so different. And the neck rate is here, and the FIP rate is here. So I'm not sure that, so in Japan, we diagnose the FIP and the neck separately, and based on the, I think, surgical pathology. And so some other country may include both FIP and the neck as a neck. So that may affect the result of the international comparison. So the neck rate is here and the FIP rate is here in Japan. So in terms of the management of the feeding management, I think because I worked in Toronto, Canada and Japan both, and I know the difference between the Canada and Japan. And I think the uniqueness of the Japanese management here, I think the first one is probably similar among internationally. We are using the early minimal enteral feeding using the breast milk. So ideally, we want to start the breast milk within 24 hours, if possible, and using the breast milk. And actually, donor milk is not popular in Japan yet. So gradually, the many NICUs started using the donor milk, but based on the national survey, still only 25% of the NICUs using the donor milk. So I think, but almost all NICU try to feed only breast milk, especially for extremely preterm infant. So some institutions wait for a while until they can get the breast milk. So that is a practice of about the breast milk. And the other thing is the probiotics. Almost all, not all, but almost all NICUs using the probiotics in Japan. And the species for the probiotics is Bifidobacterium brevi. And I think many institutions is doing the centrifuge and separate the, how to say, the powder and the fluid. And they usually use this only fluid part to give the baby. So this is because this, how to say, the powder part may not good for the gut for the preterm infant. So usually it's good to use this upper part fluid to give these probiotics. The other, I think, I don't know in the practice in Australia, but in Canada, they don't use this glycerin enema. And in Japan, most of the NICU using this regular glycerin enema. This is so the mixed with the water and diluted, usually 25% diluted solution, and 2 to 5 cc per kilogram, usually 2 milliliter per kilogram per dose, and 2 or 3 times per day. And many institutions starting this glycerin enema soon after birth or around 72 hours after birth. And especially when we have an extremely small baby, severe small gestational age, there's some baby, many baby have a problem of the mechanism-related ileus. I'm not sure in Australia, do you discuss this disease or not? But in Japan, usually we are very careful to prevent or treat of this mechanism-related ileus. This is different from a mechanism ileus, which happen to the cystic fibrosis. That is a different disease. This is a very common condition for very small baby, especially small for gestational age babies. And so to prevent or to treat this condition, we tend to use a high frequency glycerin enema, 3 or 6 times per day. And if the baby have some trouble, problem for this, we may use enema contrast. And some NICU also use the contrast, give the contrast into the upper gastric, so stomach, not the intestine. So that is some NICU using the contrast, giving the contrast in the stomach. So that is a condition. So that is all about the feeding. Before ending this presentation, this is the paper published in last year. I wrote this review article, the clinical management and outcome of extremely preterm infant in Japan. And this is a free online free access. So if you are interested, so I briefly summarize the general Japanese management, including the circulation, respiration, nutrition. So if some of you are interested in that overview, please refer to, probably it's good to check this paper. Thank you very much.
Okay, thank you. So our scheduled time is already over, but still quite a few people online, so we want to continue Q&A session as long as possible. So please open your chat panel.
Thank you. That was wonderful. So we have many questions online, and Dr. Kusuda has access to them. So we might start with one from Dr. DeWall in Newcastle. He says he's worried about cord milking and IVH in this vulnerable group. The video showed a large hemodynamic change. Is it possible for Dr. Hosono to tell us about that?
Yes, so speaking, maybe umbilical cord milking is effect of the hemodynamic status, but our randomized control study shows no difference in the IVH rate between control group and milking group. So, but there is no experience to the very, very tiny baby born at less than 24 weeks. So we believe that this procedure is very effective in 24 to 28 gestation babies, I think.
Dr. DeWall?
No, thank you. So look, I am still a bit worried because the large trial in America had to be stopped because of increased risk. And just from physiology, one would expect that the risk would be even higher in a 22, 23, and 24 week group. And them dealing in their very small little parts with this large volume bolus is can be challenging, I think.
Yes, I think very tiny baby is very different over the 24 weeks of age. So it is a trial. We need there is a trial.
Can I answer that question again? So as Dr. Hosono explained, Dr. Doal, I think we have to be careful about the interpretation of the randomized control trial performed in the USA. I'm not sure USA, I think, because the way to do the cord milking is very different between Japan and the USA trial. Because in the USA trial, they strip the cord milking very fast and many times, I think 3 to 4 times. And that is a very very different in a way we do in Japan. In Japan, as Dr. Hosono showed, usually only one stripe and usually try to do that slowly. So of course, there are some, we don't know the risk of the IVH. There are possibility of the risk of the IVH, but I think the difficulty is the result of the USA, the large trial, would not be applicable in Japanese situation because we are doing that in a different way.
Thanks for explaining. Thanks.
Mm-hmm. Of course, there are possibility. Yeah.
So probably these are very tiny babies. So maybe we need cord blood transfusion. But dilemma is that's why maybe hemodynamic change is so large for tiny infants. So this is kind of a dilemma. We want to give blood, but if we give blood, maybe can affect. So we need maybe good, well-controlled clinical trial to see the safety and effectiveness of cord milking to these tiny infants. So probably.
Can I ask to the Dr. Ogawa in Nagano? because in Nagano, you have a very good outcome for the extremely preterm infant. So do you do the cord milking for the 22, 23 weeks?
Of course, I do cord milking preterm infants. Yes.
22, 23 weeks too?
Yeah. Yes. Maybe the same way. Same way.
Okay.
Yeah.
Okay. Yeah. So,
Dr. Kusuda, maybe you choose the questions to answer. There are lots of them.
Okay. So
we probably go for another 10 minutes.
Okay.
Yeah.
So if everybody okay, so continue another 10 minutes. So maybe question about the rescue surfactant treatment. So from Seishi Gotomakara, early rescue surfactant is preferred over prophylactic surfactant, but we want to know your practice in delivery room. So Dr. Hosono or Dr. Hirano, either of you can answer this question. Or anyone?
So we give the surfactant soon after birth and after of course, the intubation. So we check the RDS as a microbubble or the respiratory condition.
So probably yes, prophylactic use is better, but we do not use universal prophylaxis. So probably after diagnosis of RDS, most of Japanese NICU use surfactant because it's very easy because we do microbubble test routinely and also take a check immediately for admission. So most of the time, less than 30 minutes, we can start surfactant. So these are not rescue. So between prophylaxis and rescue, so we use only who needs surfactant.
Okay, in my hospital, I don't like to use the prophylactic use of surfactant because I'm worried about the bad aspects of the prophylactic surfactant treatment. Sometimes if the intubation is too deep, so I worry about not spread out uniformly in the surfactant. Sometimes it causes air leak or something. So I think within 6 hours after birth, I think it's okay as long as the baby's heart rate was stable. And after checking the chest X-ray and then administer surfactant, that's still no problem, I think.
Hi, Iski. You talk about the micro bubble. I don't think many people know how to do it. Do you have a side lab in your? I mean, we did it in the something like 30 years ago. So every unit has got a side lab to do it.
Yes, almost all of the NICUs in Japan, we have microscopic system, and also we have a technique because it's very easy. So even residents can do. So all preterm infants admitted NICU, we take a gastric aspirate and do a microbubble test.
The microbubble is more like an early target treatment. That's what we do in the 30 years ago. We do that. But not many, but the problem is setting aside lab in the unit is just a lot of OHS, they can not allowed to do it anymore.
Yeah, you're right. So this is kind of a target treatment, but still we are using, and also we think this is the best way to prevent the unnecessary treatment of surfactant. Okay, so next question is very simple. why do you dissolve surfactant in 3 to 4 ml saline? Who can answer? Because Quicksilver is, I think, 2 ml, right? But surfactant, we should dissolve in 4 ml.
Can I have a question? This 3 to 4 milliliter is much for Australian country? Too much?
We don't dissolve our surfactant straight from the bottle into the baby.
Okay, so you have liquid.
I think that's a difference of the product. So in Japanese product, we have to solve the surfactant into the 4 milliliter. But sometimes we are worried about the volume, so we try to use the less fluid. So that is the reason why we give the dilute using the 3 to 4 milliliter for 1 kilogram baby.
Package insert.
Okay, okay.
4 ml. Okay, so next question is, will delayed cold clamping affect resuscitation in micropremies? So Dr. Hosono.
Yes. So in Japan, there is a specific delivery desk for delayed cold clamping use. So in Japan, umbilical cord milking is only used in the tiny baby. But US, they have a special resuscitation desk for delayed cold clamping. So I have no experience with such a desk.
Okay.
So can I ask all our Japanese friends, you do not do delayed cold clamping?
I think so. I think delayed cold clamping is not popular yet in Japan. I think everybody knows that we have a large, so as we discussed, we have a large trial show that milking may increase IVH. So in Japan, in the future, some institution may start using the delayed cold clamping, but I think currently, I think most NICU using only milking, as in my understanding.
I agree with Dr. Isayama. I never tried delayed cold clamping for the 22, 24 weeks gestation babies.
We are into delayed cold clamping. We knew that when we went to Japan in 2015 and 16. Now, we talk about, I think there is a slightly different approach. The delayed cold clamping will appear to be more physiological transfer, but it takes more time. And all that, and that you with your cord milking, you will be able to start your resuscitation as well as keeping them warm very quickly. I think they are in Australia. There's a group who believe in physiological cord clamping, and we start resuscitation at the bedside. I think there is merit in either side. I think the message we got from you guys is your cord milking is not the aggressive cord milking has been into the trial. And that is the same as what we look at in our delayed cord clamping.
Actually, according to our network database, about 25% of infants born before 26 weeks of gestation received any type of cord blood transfusion. So only 1/4 of the infant received cord blood transfusion. And also already discussed, most of them are by cord milking, not delayed cord clamping. So unfortunately, cord blood transfusion is not common in Japan yet. But if we need cord blood transfusion, we prefer cord milking rather than delayed cord clamping.
There's a lot of differences, some of the practice differences, including the one that antenatal steroid. We are Australia for almost like 99% go for it, while in Japan it's only about 40% and gone up now recently up to 60%. But they have one of the best outcome in the world. So it's very hard to say we don't whether we believe the Japanese way or actually or the what result from the randomized control trial. So,
Yeah, Key, you are right. So even recently, maternal glucocorticoid use is around 60%. So of course, this is obstetrician's decision, but we ask to use, but still around 60%. So maybe this would be our future gift. Once obstetrician use more antenatal steroid, maybe we can see more improved outcome. So maybe our future gift.
yes.
So it will be better than now.
I like to make a comment. In fact, when we travel, we went to Japan, we went to Sweden. The practice is quite different. But I think the one thing is very common in Japan is the attitude towards the extremely low gestation baby are very different. And it's very similar to Sweden. And also the other difference is all the care are delivered by neonatologists on site. So they have neonatologists who will stay there and sleep and will resuscitate hands-on right from the word go. Same is in Sweden, in Finland, all the very good in the outcome. So I think we need to look at the whole management as a package, not focusing on just one or the other.
Yeah, you're right. So probably we have other several questions. So about nutrition, rate of increase in enteral feed volume per day. What's the rate of volume increased per day?
From Kitasato University, it's okay. I think it depends on the baby's birth weight. If the birth weight is less than 1,000 grams something, usually started at 0.5 milliliter per times and 8 times per day. And we goes up by 0.5 milliliter every day. And if the baby's body weight is more than 1,000 grams something, we started at 1 milliliter per times something, and then increase by 1 milliliter every day. It depends on the birth weight of the infants, I think.
And also, question.
Oh, that's good.
Oh, okay.
Oh. Oh, that's very complex.
Yeah, not so complex, it's very easy.
So this is from NIH manual?
Yes, that's right, yes.
Okay. So also about nutrition, if you do not have donor milk, how to get breast milk from all mothers? How to?
That's a very difficult to answer because we don't. We have a very brief survey nationally, and we found that the donor milk was only used 1/4, 25% NICUs. But actually, I'm not. I was surprised the result because I think I believed many NICUs are using the donor milk, but the survey showed that not. But so I don't know about the NICU which are not using the donor milk, how they are managing the baby whose mother don't have whose mother cannot pump the breast milk enough. But so I'm not sure. I think I believe the participant today, all NICU, using a donor milk. Are there any NSU in Japan? Do you don't use the donor milk today? Nagano, Osaka, Kitazato.
I don't use any donor milk.
Okay, so in this case, how do you do for the baby who don't have access to the breast milk or mother's milk?
That's very difficult questions, and simply to say, just I'm waiting for the mother having the
How
breast.
long?
2 to 3
A
days.
week?
2 to 3 days, and until that time, generally we started from the probiotics only, with the bacterium only, and then we wait for the breastfeeding coming. How about other institution?
Okay, so probably the number of online is diminishing, so maybe the time to
Yes.
finish
We
today's
are
meeting.
down from almost 100 to 77 now.
So
we probably need
yeah.
part 2 and 3 of this.
Yeah, probably
yeah.
we're gonna have next opportunity.
Yes, that was wonderful. Thank you very much. And if you haven't had the opportunity to get your questions answered, maybe we can talk privately offline with our Japanese friends about that. There are quite a few questions in the chat room that are very pertinent to our experience. So once again, arigatou gozaimashita. Thank you so much for all your time, and look forward to going skiing in Nagano, actually. And shopping. Yeah.
Hot springs.
Hot springs, onsen. Yeah. So thank you everyone for logging in, and this this meeting is recorded. I will send around the link as soon as it finishes.
So probably we can answer all questions later by email or some way.
Lovely.
And also,
thank you.
And looking forward to another opportunity. So thank you for all participants today.
Thank you for sharing your expertise. Bye-bye, everyone.
Okay, bye-bye.
Bye-bye.
Thank you. Thank you.